Hi, I'm Rose Dunn. I hope you enjoy this brief introduction to a selected aspect of HCCs.
Okay, now there's some documentation issues with HCCs that we all need to keep in mind. The documentation, in order for it to be valid from which we can code, we know it has to be face-to-face from a authorized or approved CMS provider. It also has to reflect the date of service and some other identifier on every page. Now, if you're electronic, that's not an issue, okay? If you're on paper, that means the coder becomes more of a coder analyst doing analysis to make sure things are there. The signature has to be there from the provider and also has to carry their credentials. So look at your electronic signatures and make sure the credentials are showing. If you're on paper, once again, that coder analyst role comes into place. We can only use standard abbreviations. So if you find that you've got someone using some quirky abbreviations, we need to have some education there. And then chief complaints, follow-up doesn't cut it. We need to know what it's follow-up for. So it's follow-up for diabetes, follow-up for CHF, and so forth. So you can see there's a role here for coders, there's a role here for clinical documentation integrity specialists, and there's a role here for HIM professionals to work on templates to capture the information that's necessary for our providers to have approved valid documentation. Now, documentation that supports the HCC assignment has to be during an encounter where the codable conditions are documented in order to support MEET, M-E-A-T. That means the provider's documentation must demonstrate that she or he has monitored the condition, evaluated the condition, assessed or addressed the condition, or treated the condition. And so there's a couple of examples here of ways that can be demonstrated, and feel free to share this with your providers on both an inpatient and outpatient basis, because the inpatient documentation helps to drive HCCs as well. Now, we all have problems with history of, and we can't code history of, and what we need to do is try to get that terminology out of the provider's lexicon and document the chronicity so that it meets MEET, okay? History of will not qualify for HCC purposes, but what we know the physician really means is that the patient has had diabetes since 2009. So we just need to encourage them to document what they really mean by that history of. It's still an active condition. It hasn't gone away. Now, CMS HCCs include some documentation guidance. Chronic conditions need to have an ongoing effect on the patient's health. We need to document those chronic conditions annually, and remember, they disappear on New Year's Eve. Chronicity, severity, and stage, associated conditions and complications, everything that we educated our physicians on for ICD-10 is true under HCCs. So pull out those crib sheets that we use to educate the physicians and re-educate them once again under this. Conditions that can contribute to an HCC and remain active status need to be documented annually. And if it's not evaluated and encoded at least every calendar year, then there's no contribution to the RAF, the risk adjustment factor. Now, often overlooked diagnoses year after year are these. We forget about the fact that the patient has an amputation. We forget about them having obesity. I don't quite know how we forget about those things, but we do.